physics. And today we are also continue for talking about glaucoma. And Dr. Haas should be talking about treatment of glaucoma. So please management. Please for your speech.
Good afternoon, everybody. Today on behalf of the local department, I have a small presentation about the local management strategy. In fact, in our clinical practice, we see many case studies. Sometimes we have difficulties in deciding the proper treatment for this case. So today I'll show some case study and we'll discuss through this case study and let's discuss what should we do. The first case is a progression with a low intraocular pressure. This is not rare in our clinical practice. Here is a 57-year-old man diagnosed with a pure vision, and he was under treatment of the triple post and his combination of bronzolamide and Camelin. And he story of selective laser trabeculoplasty in both eyes. And on treatment, the RP is quite well controlled with a range from 10 to 30 mmHg. On examination, he had a good visual acuity, thin corneals, about 500 micrometers in both eyes, and RP is quite well. And here's a photo from us between 4 years. We can see that the right optic nerve demonstrates a clear progression within 4 years, and the left nerve remains stable. And the right visual acuity also, the right visual field also shows progression in the right eye. We still see this case in our clinical practice. And we sometimes are very confusing what is happening and what should we do. So there are some issues to consider. We have to find the reasons. We can think of diurnal RP fluctuation, nighttime RP elevation, the poor compliance, thin corneal, intermittent angle closure glaucoma, low blood perfusion, sleep apnea, or some neuroophthalmic disease. The last option is RP still not low enough. So the intermittently high RP seems the most likely scenario. We know that the intraocular pressure fluctuation have been shown to be associated with the progression of glaucoma in many studies. And in this patient, the peak RP during 12 hours will occur with 16 mmHg. And the RP on check is the 10 mmHg, so the fluctuation is around 5 to 6 mmHg. And there is a fact that the nighttime RP measurement is not easy to obtain. In the modern world, now today we can obtain the 24 hours of fluctuation by a special device that can implant inside the eyes. But now we don't have that device. And so, the therapy for the glaucoma patient is ideal. That's something that can provide consistent 24 hours RP control. And we have several groups of medication like beta blocker, PGA, carbonic anhydrase inhibitors, etc. And among them, PGA and carbonic anhydrase inhibitor provide RP reduction, and they should be considered as the first line to control RP. The second option is the subacute angle closure glaucoma. And in this patient, it seems unlikely because on endoscopy we open wide open. This patient has a thin corneas around 500 micromet, so the true RPs maybe are not in the low teens, maybe they are higher than 10 or 11 mercury, like we have checked in the office. And the thin corneals can artificially low RP measured by applanation telemetry and can give us a false impression of controlled RP. And when we have such a low RP, we are so satisfied and we think that's enough. But if the patient has a thin corneals, we should estimate the real RP to have a proper strategy of treatment. And the thin corneals are also a risk factor for glaucoma in ocular hypertensive and also cause the progression in glaucoma. The poor adherence. Here is always a consistent problem for chronic glaucoma management. We know that as many as nearly 60% of patients with glaucoma may be non-compliant with the medical therapy. And this can mimic good RP control. There is the fact that many patients only use their drops a few days preceding each office visit. So when they come to us, they have a very good RP, and you think that's their real RP. But in fact, due to the poor adherence, they have a very high RP at home, and we cannot catch those moments. And furthermore, we are ophthalmologists. We are not good at identifying the non-compliant patients. As a result, it can be difficult to distinguish non-compliant patients or the lack of efficacy of the therapy when the high RP is observed during office visit. Low perfusion pressure is also one possibility. Both low diastolic perfusion pressure and sleep apnea have been proposed as a potential risk for progression. These situations may lead to chronic ischemia of the optic nerve or hypoxia of the optic nerve, and this can lead to the progression of the optic nerve in glaucoma patient. And we don't forget non-glaucomatous causes of optic nerve disease. There are many other entities related to ischemia, inflammation, masses of the optic nerve that also can cause progressive optic nerve damage. And the patients with the following characteristics should be considered to do neuroimaging to rule out non-glaucomatous process. When we see the optic disc pattern and cupping, when the visual field defects out a proportion of cupping, when the defects are bilateral, homonymous or vertical aligned visual field defects, or the patients have only loss of central visual acuity, or they have afferent biliary defect without asymmetric cupping. Maybe the patient is true glaucoma, but they have another disease of optic nerve, and this also causes the progression of the visual field and on the optic nerve. And if we identify these situations, we can treat this disease and we can hold or stop the progression of the patients. About the treatment, when all of other possible explanations has been ruled out, there is one thing we can do is to lower RP even further to protect the optic nerve. And this patient was underwent tracheotomy with a mitotic C in the right eye, and RP after the surgery consistent in 8 to 11 mercury, and he had no further structural and functional progression over the next several years. That's the first case study. The case number 2 is selecting adjunctive therapy when immunotherapy fails. Here's a 43-year-old man diagnosed with open-angle glaucoma and high myopia. His peak RP in the right eye is 30 and left eye is 24. and he is under trouble post, one sitting for right eye only. On examination, he had good acuity 20/20 in both eyes with refractive correction. On slit lamp, we observed the faint peripheral radial slit line transillumination effects, and more prominent in right eye, no cupping spin over observed. The RP under treatment or 23 with curing right eye and 19 in the left eye. The pachymetry is normal. On rotoscopy, the eyes are angled. The 4+ pigmentation in the right trabecular meshwork and 3+ in the left, and no iris backbowing were observed on clinical examination or on OCT. On fundus photo, we can notice here early neuroretinal green loss and early retinal fibrillary effects on the right eye. Here. And the patient was diagnosed with pigment dispersion syndrome with the early pigmentary glaucoma in the right eye. In fact, the travel post regimen in this patient has been reduced the RP in the right eye up to 25%, from 30 to 23 mmHg, but that seems not enough. Within 2 years, the progression in the visual field phase has been shown with the inferior nasal side, and the target pressure must be lower. And now is the time for us to think of adjunctive therapy. So in this case, the adjunctive therapy maybe medical, maybe laser. For medical therapy, now we are in the era of fixed combination medications. Here we can tell that there are many fixed combinations, like benzodiazepine timolol, timolol-ranitidine, or benzodiazepine-ranitidine. And this fixed combination can be used as first line or as first adjunctive therapy. And when this combination added with the PGA, it can also reduce additional RP up to 5 or 6 mmHg. And the fixed combination has many benefits. It helps to reduce exposure to preservative. It helps to eliminate the washout effects when you use many eye drops at the same time. For laser, SLT now is widely used, and it has effect of lower RP as good as the PGA. It can eliminate the concerns regarding the adherence to medical therapy. But with the pigmentary glaucoma, there is one thing to pay attention is that we should lower the power to prevent the damage to the densely pigmented trabecular meshwork. Case number 3 is the glaucoma coexisting with ocular surface disease. This is a very common problem we usually see in practice. And here's just one case. There's a 56-year-old woman diagnosed with a POEJ, and she was initially managed with hematochrome in both eyes. And peak RP on treatment was 24 mmHg in both eyes. It's not very good. On examination, the visual acuity is quite well with the hyperopic correction. Pachymetry is normal, RP. On examination is 90. And on rotoscopy, the open wide angles with a moderate pigmentation in trabecular meshwork. And this patient has a rather long timeline of the treatment. After 6 years of treatment with the hematochrome, the RP gradually rose over the target RP. And of course, the visual field show progression loss of the inferior field in right eye, and this confirmed with the superior retinal fibrillary filling on OCT. And after that, the patient has been indicated adjunctive medical regimen include the hematochrome, timolol in both eyes, and beryllium in the left eye. And the RP range, very wide range from 10 to 19 mmHg on both eyes. In the last 2 years, And then she came and explained foggy visions, difficulty with the near-sight tasks like writing, reading, sewing, and sleep lamp. You can see a mild superficial punctate keratopathy in the both eyes. So ocular surface disease commonly coexist in patients with glaucoma up to 50% to 60% of glaucoma patients. This is due to the chronic exposure to the components in glaucoma medications, particularly the preservative BPA. This can cause a change in conjunctival alignment, permeability, anatomy, and function. And this change are those dependent, cumulative over time, and translate into clinical symptoms. And many studies have shown that the topical glaucoma medications preserve VAK have a threefold high risk of developing symptoms of OSD compared with medication-free VAK. And that's why nowadays the glaucoma medications have some innovation. They have alternative preservative like Sosia, the purite, the Bacillus microbes, or pre-preservative. And these alternative medications have a few effects on ocular surface cells. And for our patients, we change medication into the preservative-free or VAK-free glaucoma medications. And then we add the preservative-free artificials with the glaucoma medications. And then we send the patients to corneal specialists. And the patients started with the cyclosporine therapy and the placement of bilateral pantoflux. But after that, you get just some modest improvement in symptoms. And a few months later, the ocular surface symptoms became even severe, that the patient became non-compliant with the RP medications. We tried to do SLT in the right eye, but no stable effects on RP. We know that not everyone responds well with SLT. It may associated with the type and severity of glaucoma, number and class of medications used, and previous tracheoplasty. And finally, after a long time, the patient was decided to do tracheolectomy. And after the surgery, the RP achieved 7 to 8 mm mercury, the right eye, and 14 in the left eye, and no need for glaucoma medication. We always maintain the free preservative artificial teeth of the patient, and she had improvement in the acuity and the symptoms in both eyes. And the last case is we discussed about selecting the correct procedure or appropriate procedure when glaucoma surgery is necessary. Here's a case of a woman, 62 years old. She had uncontrolled POAG in the right eye. She had a treatment regimen included travel post, Bramolene, and fixed combination of doxorubicin and timolol twice a day of the right eye. Both eyes had been done SLT. The right eye had been done tracheolectomy with the marginal C, and the right eye was complicated with the post-operative blebitis. After that, she was successfully managed with vision loss. On examination, the vision acuity is good, 20/30 in the right eye. RP in the right eye is 25, the left eye is 7. She had a nucleus sclerotic cataracts in both eyes and open endoscopy. And here's the visual view of the patients. You can see that she had asymmetric glaucomatous damage and silver stage in the right arm. So the problem, the issues that we have to consider is that the right eye really needs to do surgery to lower RP, but the procedure must be safe to prevent the event that may cause vision loss. And trachelectomy seems ideal, seems desirable for this patient because she had uncontrolled POAG with a maximal medical therapy and SLT treatment before, but she had history of post-op complication of leg related to infection, and this that is threatening to the vision. Luckily, now we have numerous novel procedures that have been developed to lower RP in glaucoma. Here I list many surgery in this table, and I introduce some procedure. For trachelectomy is the gold standard. It's the most common performed incisional procedure for glaucoma. It creates a scleral fistula to allow draination of the humor from the anterior chamber into the subconjunctival space. And the antifibrotic agent is used routinely to modulate the wound healing. But besides its benefits, it has undesirable effects like hypotony, leg-related complications, including or infection. It's very dangerous and vision threatening. The tube shunts is alternative to trachelectomy, in which we use a device with a silicone tube shunts to drain the aqueous humor from the chamber to a reservoir, usually placed subconjunctival. There are two categories, one with the internal flow restriction with the Ahmed valve or Kupin valves, and the other categories is those that do not have a valve structure, like BVL or retainer. And before, this device had been reserved for eyes at high risk for filtration failure or as a second choice when we had a trachelectomy failure in the past. But now, in recent years, the use of the tube shunt surgery has been expanding. We have a very large study that compare the effective and the safety of valve surgery, of tube shunt surgery, and trachelectomy surgery. And the tube shunt surgery shows the same efficacy and safety with the trachelectomy. Express mini shunts is very familiar with us because we have used this device in our hospital. They represent a hybrid of trachelectomy. It consists of a small steel tube inserted into the anterior chamber to create a translateral shunt of a humor from the anterior chamber into the subconjunctival bladder. And it has advantage compared with the trachelectomy because it has fewer complications and faster with the recovery. The price is not very low. And now for these two cases here of minimally invasive glaucoma surgeries, these procedures have some characteristics. They are up internal approach to secure that the globe is always in a closed system. The minimal trauma to ocular tissue, modest efficacy, excellent safety, and rapid post-operative recovery. And it's usually performed in combination with the cataract surgery. And given the efficacy and safety profiles, they are best used in patients with the early or moderate stage who do not require very low RP.